Great. Well, I'm really excited to introduce our next keynote speaker, Dr. Ruth Keogh, who is a professor of biostatistics and epidemiology at the London School of Hygiene and Tropical Medicine, where she is also the co-director of the Center for Data and Statistical Science for Health. With that, I will let you take it away. Looking forward to your talk.
Thanks, Sarah. And thanks so much to Sarah for the invitation, and to all the organisers of this conference today. So yes, thank you very much for the introduction. I am going to talk on this topic of when prediction meets causal inference. And I thought I'd just start by giving a little brief introduction to myself and my what my interests are. So I'm based at the London School of Hygiene and Tropical Medicine in the Medical Statistics Department, which is in a faculty of epidemiology and population health. I don't know, some of you might have been to the London School. This is a picture of our building in London, which if you haven't been to the school, you might have been to the British Museum, and it's very close to there. I don't know whether you can see very well on this picture, but around the top of our main building, there's all these names, which you can't see what they are in this picture, but names of famous scientists. And until about 5 years ago, I think these were all men, and the school decided that needed to be rectified, and so they added some names of some women scientists, including Florence Nightingale, to the school. So if you're passing or you're going to the British Museum, come by and see some of these names on the side of the school. So my research interests are broadly in methods for the analysis of observational data, and particularly in time to event analysis and causal inference methods. And that's going to be sort of the theme of my talk today. But I've also done work, and I'm interested in a number of other areas, handling missing data and measurement error, case control, study design, and also in applications of methods in a number of different disease areas, particularly in cystic fibrosis. That's one of my major interests in terms of applications, but also in other areas like cancer, transplantation, and kidney disease, for example. So that's just a bit about my background. And Sarah kindly mentioned the Centre for Data and Statistical Science for Health that we have at the London School of Hygiene. And I just wanted to have a couple of slides on this. And we actually had a contribution from members of the centre earlier in the day at this conference. So some of you might have heard this before. So the centre, or DASH as we call it, is focused on the development and application of statistical and data methodology to address some of the major challenges in health. And we focus on these three particular challenges: developing and evaluating diagnostics and interventions, informing health policies that improve population health and reduce inequalities, and improving environmental and planetary health. So just a little idea of what our aims are in that centre. And you can join the centre by, or you can, this joining basically means adding your name to an email list. We don't send excessive numbers of emails, but you'll then get notified about any seminars or events or training that is going on. So that's just, I wasn't clever enough to put a QR code there, but I'm sure you'll find the relevant page if you have a look. So on to the topic of the talk. I wanted to give kind of a bit of a general talk, which is an introduction to some different areas, but also so it's quite general in a way. It's also linked to some of my areas of interest. And part of the background to this talk is this nice paper from Hanan and colleagues, published a few years ago in the journal Chance, on a second chance to get causal inference right, a classification of data science tasks. And in this paper, they basically said that when we're doing medical statistics or data science, we're basically doing one of three things. We're either doing description, we're doing prediction, or we're doing causation, or trying to answer a causal question. And this wasn't really a new idea in a way, but it was a very nice paper that described the fact that it's not always clear what what type of research question we're answering, and it can be useful to try and classify the types of tasks we're doing or the questions we're trying to answer in this way. And there's also this earlier paper from Shmuley on to explain or to predict, which discussed very much some of the same ideas. So in this talk, I'm going to be focusing on prediction and causation. That's not to say that I don't have any interest in the third option of description. I think that's something that's very often, unfortunately, neglected, doing nice descriptive analyses. So let me say a bit about how they define prediction and causation, and then the theme of the talk is really going to be talking about some of the links between these two things. So in the paper from Hanan, they describe prediction as being about using data to map some features of the world inputs to other features of the world outputs. In this other paper from Shmuley, they described it as the process of applying a statistical model or data mining algorithm for the use of predicting new or future observations. In causation, on the other hand, well, some different terms were used in these papers. Hanan used the term causal prediction, and they describe this as being about using data to predict certain features of the world as if the world had been different. And we'll talk more about this a bit later in the talk. And in the other paper, they said, I define explaining as causal explanation and explanatory modelling as the use of statistical models for testing causal explanations. So there's a lot of tools that we use as statisticians or data scientists when we might be working on building a prediction model or answering a causal type of question. So the types of tools that we might use traditionally when building a prediction model are things like we are thinking about what measures of predictive performance am I using? Am I doing some external validation or some kind of cross-validation to evaluate the performance of my model? And I'm likely using some techniques such as regression modeling or machine learning methods, for example, to obtain those predictions. When we're trying to answer causal questions, we are thinking about things like what's our causal estimand? How can I deal with confounding if I'm outside of a randomized trial setting? Maybe I'm thinking about using the trial emulation framework. And then, of course, you know, there's a lot of overlap between the kinds of techniques we might use, like regression modeling, for example, to actually do the statistical analysis. So we can already see there's quite a lot of overlap, particularly in maybe the final steps of the mechanics of what we're doing when we are answering a question about prediction or a causal question. But there's quite a lot that's been kept separate about these two areas. There's obviously a huge literature on both of these areas, and I just picked out some books that well known, and I found particularly useful this book on clinical prediction models from Steyerberg, the What If book from Hanan Robbins, and the Book of Why from Pearl, but of course many others. So what I wanted to focus on in the rest of this talk is what can prediction tools do for causal inference, and vice versa. What can the tools that we might be more traditionally using causal inference do for us in prediction? Thinking about the fact that these things are kind of often kept separate. We might think, oh, I'm a person who works on prediction, or I'm a person who works on causal inference. But in terms of the toolkit that's available to us as statisticians or data scientists, I think there's a lot that can be learned from each area. So I wasn't quite sure which one to start with. I started with this one. So what can prediction tools do for causal inference? And I have to say that it takes a little bit of time to get to the punchline in this one, whereas I feel like when we're going the other way around and thinking about use of causal inference tools in prediction, that's more something that comes right from the beginning and the point of asking the question, but we'll come to that later. So there is a bit of build up in this next part. So causal questions And I'm thinking about this in a healthcare setting and from the point of view of observational data. But we can think of a causal question. Let's suppose we're interested in people in the effect of a new treatment. So we might think of a set of people who are eligible in some sense to receive this new treatment. And the causal question is something like, what if everyone had received the new treatment? Or what if no one had received the new treatment, or everyone had received some kind of standard treatment? So a causal question is a what if question. And this goes back to the definition from the paper of Hanan. It was a question about what if the world had been different? So ideally, if we were trying to answer a causal question, what we would really like to see, we'd like to see everyone in these parallel worlds where everyone had received one thing or everyone had received another, but mostly that's impossible. And so we do things like we might do a randomized trial to mimic that kind of idea, in which case we don't worry, at least if our trial is nicely conducted and everything worked out well, we don't worry about confounding. I'm interested in the setting of observational data where instead of having randomization, which is going to control for confounding, at least we hope, we're thinking about observational data in which instead of observing people, half the people under one condition and half the people under the other, we observe the real world in which people are receiving one treatment or another. People are receiving treatments for a reason, and reasons that make people who receive one treatment or another systematically different from each other. But it's still useful to think of the question that we want to ask as a what if question. So we've got this real world where people are taking a mixture of, we're just thinking about treatment or no treatment in this example. But we can still say, well, even though that's the data I'm faced with, I want to use that data to answer a what if question. So what if instead of seeing this complicated real world, I'd seen everyone under the new treatment and I'd seen everyone under no treatment or a standard treatment. And this helps us to define our estimand, which is kind of the starting point for a causal analysis to specify clearly what exactly it is that we want to estimate. So I'm going to focus in this talk on the time to event setting, because that's the particular setting that I'm interested in. But much of this applies if we had a binary outcome, if we had a continuous outcome. So in the time to event setting, I'm going to thinking of this idea, this what if this or what if that. I'm going to define the counterfactual event time for each person in my observational data set, which is my real world data, under treatment as being T1, and my counterfactual event time for each person under no treatment as T0. So we don't observe both of these for each person because we only observe people under one condition, treatment or not. But this is helpful for defining our estimand. So our causal estimand, I'm going to think, let's suppose it's not necessarily this, but I'm going to think we're interested in a risk difference. So we're interested in someone's risk of having some event of interest, which might be death or a disease diagnosis, some adverse events, often in the healthcare setting. What would the risk have been up to a particular time, little t, if everyone had been treated versus everyone had not been treated? So that's over the next few slides what I'm going to be thinking about. That's our target of estimation. And I'm just going to, for the next few slides, keep this little diagram on the left-hand side to remind us the kind of setup that we're thinking of. So we're thinking of observational data in which people are followed up over time. And so I've just drawn that for 10 people here. And we've got two colours here representing some people are observed to receive the treatment of interest, which we call A equals 1. And some people are observed to be untreated for that thing, A equals 0, so represented by the green and orange. Baseline, which might be a disease diagnosis, for example, or it might be the time of some event occurring or the time of reaching some eligibility criteria. at that time, we observe a set of baseline characteristics, which I'm going to denote L. And over time, people are followed up for some event of interest, which is the red crosses here. And of course, some people are not going to have that event, so they're going to be censored for one reason or another. So that's kind of the type of data that we're thinking of. We're going to be thinking about estimating, maybe I should have put these the other way around, this estimand at the bottom. So this is the risk difference that I defined on the previous slide. That's our target. But estimating that thing from these observational data, where we have these relationships that are depicted in the DAG here. So I'm assuming that I've got treatment A is affecting the time to the event T, but I've got confounding by these baseline variables L. I've also got some censoring going on, and maybe that censoring also depends on both your treatment and your other characteristics. So I am focusing on a simple setting where we've just got a point treatment, so nothing time dependent going on here in terms of the treatments or covariates. But a lot of this, of course, extends in that direction. So how can we estimate this thing, this estimand of interest, this risk difference, this what if question? How can we estimate that thing from data like this when we've got confounding? There are two main choices available to us for addressing this confounding. We can either do it by using a model for treatment, i.e. a propensity score model, and then reweighting the data, or we can do it by using a model for the outcome. And in the time to event setting, we have this extra thing that we need to be thinking of, that we shouldn't forget about the censoring. And so I'm not going to say too much about the assumptions. I'm going to focus a bit more on the methods, although I'm not going into huge detail about the methods. I'm just trying to give an idea, an overview of them. But in order to estimate this thing from the data that we have available to us, we're going to need to make some assumptions. I've just written those here. So these are the exchangeability assumption, and also an assumption that the censoring is independent of the event, conditional on what we observe. And we've also going to be making the usual assumptions that we're making in causal inference of positivity and consistency. So we're going to assume for the rest of what I talk about that these assumptions are met, although of course, in reality, those are big assumptions that we should think very carefully about whether we believe they're met. So we just say a bit more about these two choices for estimating the treatment effect, or estimand, from data like this. So our first choice I mentioned was about using a model for treatment. So this involves using a model for treatment A, conditional on these baseline characteristics L, and our inverse probability of treatment weight is 1 over that, 1 over the probability that you received and the treatment you received. In this time to event setting, we, as I said, we should also be worried about the censoring mechanism. So it might be that we are lucky and we believe that the censoring is totally random, but maybe it's quite often the case that censoring does depend on certain characteristics. And at least for me, I'm a bit more used to working with regression models, which I'll talk about on the next slide, which kind of deal with the censoring for free in a way. But that doesn't happen when we use inverse probability of treatment weighting. So if we're using inverse probability of treatment weighting, if our censoring depends on some covariates, then we're going to need to deal with that sort of as a separate step in our analysis. So one thing we might do is also use some weights to deal with the censoring. So here I've got an inverse probability of censoring weight, and these are always going to be time dependent things because censoring is something that happens over time, and it's basically 1 over the probability of remaining under observation at a given time. And once we've estimated these weights, which we can estimate from our data under the assumptions stated on the previous slide, I can then perform an analysis, and it might be, for example, a weighted Kaplan-Meier analysis where the weight at a given time will be the product of the treatment weight and the censoring weight. So once we've estimated the weights, the analysis itself might be quite simple. Our other option, as I mentioned, is instead of using a model for treatment, is to use a model for the outcome. So this might, and there's many different things that this model could be. But for example, we might specify a Cox proportional hazards model for the counterfactual outcome. So this is a model for the hazard, but thinking about the counterfactual event time rather than the observed event time. So it's specified in terms of treatment status A and these baseline covariates L. And then we argue to ourselves that those assumptions that I stated earlier are met, and we can therefore fit this model directly using our observed data. So we can, I've written the model as a marginal structural model in a way, and it's in terms of these counterfactual event times, but I can fit it, I can estimate the parameters of that model under those assumptions using this data at hand. And that's because it's got the L's in there. Based on that hazard model, I can then obtain conditional survival probabilities. And I do that for each individual in my data. So I've got 10 individuals here. So for each of those 10 individuals, based on the hazard of this Cox model that I fitted, for example, I would obtain their estimated survival probability up to 5 years, whatever's of interest, if they've been treated. So setting A equal to 1, no matter what their actual treatment was, and setting A equal to 0, but keeping their L variables the same. So they keep their individual characteristics, but we say, what would their survival have been if they had A equals 0 or 1? This gives us conditional survival probabilities, and then we simply take the average of those to estimate our probability of interest, or 1 minus those I've written here. And this is, a simple version of the G formula. This is just standardization. So I did tell you this bit was a little bit long-winded about getting to the prediction part, where the prediction comes in, but it's coming before too long. So we've talked about these 2 ways of estimating this causal demand that we might be of interest, using a model for treatment, plus it turns out a model for censoring that we should be thinking about, or using a model for the outcome. Now, we need to specify these models, and so if we're using the first of those methods, so using a propensity score approach, we have to get those models right. So we're probably, let's say, using a logistic regression model to estimate the probability of treatment given baseline variables L, and we might be using maybe a Cox model to estimate the censoring probabilities. And if we get those models wrong, which is, well, I'll say more in a minute, is quite likely that we do, particularly if we've got lots of covariates L, then we will get biased estimates of that causal demand of interest. And similarly, using the other approach, if we're doing it by using a model for the outcome, then we've specified this hazard model. We have to get that model right, and it has to be right both for confounding and for dealing with confounding and for dealing with dependent censoring. And again, this model could be wrong. We might have non-proportionality of hazards. We might have interactions between things that we haven't put in that model, for example. So as we know, all models are wrong, but we can build on these approaches, or there's lots of methods that have been developed that build on these 2 approaches that help us to do a little bit better. So to make slightly fewer modelling assumptions. And this is the basis of so-called doubly robust methods, which there's been a lot of work on such methods over recent years in the causal inference literature. And doubly robust methods work in such a way that we get more than one chance to get a consistent estimate of our causal demand of interest. And as it turned out, they also strongly related to and open the door to incorporating machine learning methods. So I've talked so far about we could be using logistic regression, or we could be using Cox regression, so parametric or semi-parametric methods. These doubly robust methods help us to go a bit beyond that. So doubly robust methods in this survival context, time to event context, they typically work in such a way that we have two chances to get a consistent estimate. We either get the treatment model and the censoring model right, or we get the outcome model right. And if we get all of those things right, then that's also good. So there's some different approaches to doing this. One is augmented inverse probability weighting approaches, but one that I'll just mention in a little bit more detail today is this targeted maximum likelihood estimation approach. And I know that there have been sessions on this approach earlier in the conference. So this is finally the bit after that rather long build-up about where prediction models, prediction tools can help us in causal inference. So I'm not going to attempt to give a very detailed overview of how targeted maximum likelihood estimation works. I feel like it's something that I'm still developing my own understanding of all the details of how it works, and I'm sure there's people here who understand it a lot better than me, but let me just try and give an outline of how it works. So TMLE, it provides estimates of conditional survival probabilities that we're interested in through a so-called targeting process. And that targeting process works in such a way that, so if we're interested in estimating a survival probability, under the outcome regression approach, which appeared a couple of slides ago, let's suppose we do that by maximum likelihood estimation. We're estimating these parameters beta A and beta L here. And that maximum likelihood approach is focused on those parameters, estimating those parameters well. But it's actually not those parameters that we're interested in. They're sort of a route to estimating the thing that we're really interested in, which is these survival probabilities. And the TMLE approach sort of helps us to target those things more directly than if we were using a standard maximum likelihood estimation. So we're going to suppose, and I'll say a little bit more on the next slide, that we can obtain targeted estimates of these conditional survival probabilities. We then simply plug those in to what we would do if we were doing the standardization or G-formula approach, and we get an estimate of that for each person given their L variables and under each value of A, and we take the average over everyone, and that gives us our estimate of these marginal survival probabilities, which is what we're ultimately interested in here. And there's lots of literature on this. So there's the book from Mark Vanderlaan and Sherry Rose on targeted learning. I think this was first described in the time to event context in this paper from Kelly Moore and Vanderlaan. And there's very nice recent work from Helen Ripgard on this topic. And I think we've also heard from Helen, unfortunately I didn't get to hear the talk, but earlier today. So I'll say a little bit more about the key steps of TMLE and where these idea of using prediction tools comes in. The key steps of targeted maximum likelihood estimation are: we need to fit three models in the time to event setting. We need a model for treatment, given our baseline covariates, which is our propensity score model. We need a model for the hazard of the outcome, given treatment and our baseline covariates. And we need a model for censoring, given those things as well. So it's the ingredients that we already talked about in the other methods, but now we're using all three at the same time. I'm going to be very hand-wavy and vague here, but it turns out that those three models get used in what is described as a clever covariate, and that clever covariate for estimating survival under treatment takes this form. It's usually denoted by the letter H, and we don't need to look at this in much detail, but just to point out that it involves the three things that we have estimated in the first step. And it's a number. We then fit a hazard model for the event, which sort of essentially includes A and L, but also this extra clever covariate that we've just estimated that is a function of these three different models. And an iterative process is then used to obtain these conditional survival probabilities of interest, and finally to plug that in to this formula to get our marginal estimates of interest. So that is a very sort of hand-wavy outline of how TMLE works, but the main point I wanted to make is that these models, the basis of it is these three models here that we fit in the first step. These could be parametric models like we already discussed, logistic models, parametric survival models, or semi-parametric models like a Cox model. They could be machine learning models, they could be derived from random forests or something like that. Very often in the context of TMLE, these models are fitted using a superlearner, which is an ensemble approach combining several prediction models together in an optimal way. And so it's in this step, this first step of this TMLE procedure, that we can take advantage of prediction tools. So, for example, let's suppose we're doing it using the superlearner, but it could be using any parametric model or machine learning algorithm. The superlearner, for example, is designed for prediction, but in this approach, it's being embedded within a causal estimation procedure. If we're using the superlearner to estimate these three models that we need, then the optimal combination is being of a set of candidate algorithms is being derived based on a combination that gives best predictive performance. So it's at this step that we're using sort of the things we know about measuring predictive performance, and also typically using, if we're making use of machine learning methods in this step, we're going to need to be using cross-validation steps in order for this all to work out. So I did sort of give an upfront apology that it took a little bit long to get to the punchline of where prediction tools are coming in to help us in doing causal inference. But hopefully this gives just a little idea of, a little introduction to that idea of how that works. There's a growing literature on this topic, and here's just a few other useful references I found useful on doubly robust methods for survival outcomes, particularly this paper from Erin Gabriel and colleagues. I think Erin was also giving a talk today, which you can find on the archive, is a very nice introduction to some of these approaches in the time to event context. So let me move on to this second part, which is about how causal inference tools can help us when we're doing prediction. And this is, we don't have to wait so long to get to how it helps us in this part. So many of us have probably developed clinical prediction models, or we might have used them, or they've been used on us through our healthcare in some way. There's lots of clinical prediction models out there on all different aiming to help us with all different things. So in this recent paper, and this is just one sort of definition of what prediction models are doing, this comes from the recent Tripod plus AI statement on guidance for reporting of clinical prediction models. And they said in this paper, prediction models are used across different healthcare settings. They're used to estimate an outcome value or risk, and most estimate the probability of the presence of a particular health condition or whether a particular outcome will occur in the future. So I'm thinking here about risk prediction models. They then say their primary use is to support clinical decision making, such as whether to refer patients for further testing, whether to monitor disease deterioration or treatment effects, or whether to initiate treatment or lifestyle changes. So I've just repeated that statement in red at the top again here. And so it says their primary use is to support clinical decision making, such as this first example, whether to refer patients for further testing. And so it seems that if we want to know whether we should refer patients for further testing, then what we really want to know is, well, what would be that patient's or my what that patient's risk of the outcome be if they did get referred for that further testing or if they didn't, and contrast those two things. And similarly for the other examples they give here, we want to inform whether a patient should initiate treatment or should make some lifestyle changes. So these are questions to me about what would the patient's risk of the outcome be if they initiated treatment or if they didn't, or if they, let's say, started exercising 3 times a week, or if they continued their current activity levels. So in order to make some sort of clinical decision, it seems that one would want to contrast what risk would be under one thing, you know, the possible choice to be made, versus something else or doing nothing. And so even though this is about prediction, these are in fact causal questions. And so in order to answer these questions, it stands to reason that we should be using causal thinking and techniques when we're trying to answer these questions. But that is very often not done in prediction modeling. But there's a growing literature on thinking about probably that is what we should be doing more in clinical prediction modeling. So this is a recent paper that I was lucky to work on with Nan van Helloven and colleagues, and Nan is based in Leiden in the Netherlands, on the risks of risk assessment, causal blind spots when using prediction models for treatment decisions. And in this paper, we looked at 3 ways in which standard prediction models incorporate treatments. Some things that standard prediction models do, and this is the sort of background to this, is that standard prediction models are not actually helping us to answer these questions that we logically should be wanting to answer if these are the kind of decisions we aim to inform. So some prediction models include treatments of interest as a predictor in the model. Some restrict to untreated individuals when they're developing the model, and some ignore treatment altogether, even though it might be being used by people in the population in which the model is being developed. So I'd say a little bit more about these 3 different things that are often done in standard prediction models. So the first is that we might be including treatment as a predictor in the model. And I'm going to give some simple examples. So we're thinking of data that, you know, maybe the same or very similar data to what we were thinking of in the context of answering a causal question. So let's suppose we've got a population which includes treated and untreated individuals. And we're going to fit a prediction model, and we're going to put treatment status into that model A, and then a set of other predictors, and we're just calling those X now. And we might do that, let's say, using a Cox model. That's a very common approach to fitting risk prediction models. And then we get this formula for the risk that looked a little bit like this, involves some baseline survival probability, and then it involves this sort of risk score term, which involves treatment A, and then a set of other predictors of the outcome. And then what would we do? Well, we could obtain people's risk, setting A equal to 1 in this model, so just plugging in A equals 1, but using the person's observed characteristics for the X. And we could plug in A equals 0 in an attempt to get an estimate of what the person's risk would be under no treatment. But does this answer the what if question? So does this answer the question of what if I, with my characteristics X1, X2, X3, etc., had got treatment, and what if I had not got treatment? Does it answer that what if question? Well, I think in general, no, not unless we got extremely lucky in these X variables that we included in the model. Because typically these predictors that are included in risk prediction models are selected as things that are predictive of the outcome, rather than things that we need to control for in order to deal with confounding, because confounding is not typically a concept that we're thinking of a lot when developing prediction models, but I suppose we're arguing here that we should be thinking of that more. And so if we'd included all of the confounders in here, then it would be valid to then plug in and make this causal interpretation of the estimates of risk that we get out of this model. But in general, that is not the case, because that wasn't how the model was set up. And here's just an example of where something like this was done. So in the PREDICT study, this was a prediction model developed using primary care data. It was a model for 5-year risk of cardiovascular disease. And in that model, one of the variables included was whether the person was using blood pressure lowering medication, as well as a lot of other predictors. And something we could get out of that model, for example, is we could set a person's blood pressure medication to be 1. And thinking, well, maybe this is going to give me what a person's risk would be under taking that medication. And this is for a particular person. And we got an 11% risk of cardiovascular disease in the next 5 years. Setting blood pressure to 0 using this model, and this is plugging real values into this model, we get an estimate of 8%. So this is a little bit counterintuitive to us. We don't really would like to be seeing that if I give someone a blood pressure lowering medication, their risk of cardiovascular disease is actually going to get higher. And the reason that, or one reason that we might get this kind of counterintuitive thing from such a model, is that the model just wasn't set up in such a way that the things we get out of it have a useful causal interpretation. Maybe I'll skip over this second, well, I'll say it quickly, but a related thing that is sometimes done in prediction modelling is to restrict only to treated individuals when we're fitting the prediction model. So in that last example, restrict only to people who are taking blood pressure lowering medication. And we basically face exactly the same issue, because by restricting, we're still conditioning on treatment status, but we haven't thought about confounding when we've put all these other predictors in. And there are some different examples of this in the literature. So the Euroscore model is, I think, a widely used model for predicting mortality after cardiac surgery. But it's actually been suggested to use this model to inform about whether for a given patient, they should proceed with the surgery at all, whereas it's not really designed for that purpose. And what we would probably want is, what would the person's risk be if they get the surgery or if they don't? And similar things have been done in the context of organ transplantation. Just a third example, which is something common to do in development of risk prediction models, is just to ignore treatment altogether. So don't put it in the model at all, even though it's there. And then say, sort of argue that this gives us estimates of risk under the current standard of care. And if risk is high, then that maybe might inform giving a more aggressive treatment or starting someone on some particular treatment. But we get the same kind of issue under this approach, in that some people in the data used to develop the model might have been at low risk because, in fact, they received the treatment under current care that people were getting. But that doesn't mean that we shouldn't offer treatment to other people with low risk. It might mean that people with low risk actually were already getting treatment, but we didn't think about that in the setup of the model. And an example that's been written about, I think, in a few different papers now, I've just referenced this paper from Matt Sperrin and colleagues here, is the Q-risk model. So the Q-risk model is used in the UK. It's a model to it's a model for 10-year risk of cardiovascular disease. And it's used in primary care in the UK to inform whether a person should be prescribed statins. So you get to a certain age in the UK and your doctor starts putting your numbers into this prediction model and gets out your 10-year risk of cardiovascular disease. And if it's more than 10%, that's a suggestion that maybe it would be a good idea to start people on statins. But in fact, well, in the model that was in the data that we used to develop this model, no one was taking statins at baseline, fine. But people could commence statins, because they were in use at the time that this model was developed, commence statins during follow-up. And it's been suggested that interpretation of risk from this model is difficult because a patient's predicted risk of being, let's say, lower than 10% might actually be driven by similar patients in the development data who in fact started taking statins over the course of follow-up, and that's what gave them their low risk. But that doesn't mean that this patient now shouldn't be started on statins. It might mean people like them in fact got statins in the data. So that's just some examples of where if we don't think about causal questions when we're developing risk prediction models, things can go wrong and we don't get out of them what we intend. There's some other nice work that I've just referenced here from Nan van Herleven again on prediction meets causal inference, where she coins this nice term of predictimans, that where we use estimans in causal inference, we should be doing that also in the prediction context. And this more recent paper from Kim Lucan and colleagues on risk-based decision making, where they provide more discussion about estimans for risk prediction, but predicting under interventions. So if you intervened and set treatment to this or something else. And just to highlight a nice process that Kim and colleagues described in this paper, it reminds me a little bit of the target trial framework. They said, well, if we're thinking about a risk prediction model, we should be thinking through these steps, which takes into account some causal thinking. We should be thinking about who's our target population to which we want to apply this risk prediction model. At what moment am I going to obtain predictions on these people? And what are the intervention options? So what is the choice to be made? Is it whether someone should get this treatment or no treatment, for example? And then other things that we would also be thinking of, both in a prediction context and in a causal inference context, like what the outcome and prediction horizon are, and then what the other set of predictors are. In this prediction context now, we want to be thinking, if we're aiming to make causal statements at the end of it, not just about things that predict the outcome, but if we're doing this using observational data, which we probably are, then we also need to be concerned about confounding. So I'm not going to say more about those methods that we might then use to do all this, but just to highlight a few papers and examples. So the paper on the top left here, a scoping review of causal methods enabling predictions under hypothetical interventions from Lynn and colleagues, gives a really nice overview and review of where these methods have been used in the literature, where they have thought about, when developing a prediction model, how it could be used in a valid way for informing decision making. And then here's a couple of examples, one from Chu and colleagues on prediction of cardiovascular disease risk, accounting for future initiation of statin treatment. So this is a little bit like Q risk, but accounting for the fact that some people start statins in the future. And a nice example from Barbara Dickerman and colleagues in the context of predicting counterfactual risks under different treatment strategies in HIV. And Nan van Herleven and I have also done some recent work where we applied this in the context of organ transplantation, and we also thought about some methods for actually validating prediction models that are developed with this risk-based decision-making in mind. So hopefully I've given a bit of an overview of how we can make use of prediction models when we're doing causal inference, which kind of doesn't come in until the last moment in a way. When we're doing the analysis, we still need to do all the causal thinking about our assumptions and everything. And then maybe in the last steps is where use of prediction techniques can be helpful to us. Going the other way, I think if we're doing prediction modeling, we should quite often be thinking about all the tools we have available to us from causal inference, really from the beginning, from the point at which we're thinking, what do I want to use this prediction model for? So I'm going to stop there. Thank you very much again for the invitation, and thanks for listening.
Thank you so much. That was great. Do we have any questions from the audience? I was making note, you brought up, I think, a ton of really great papers to take a look at to kind of get next steps. As someone who's new to, honestly, causal inference and prediction, are there one or maybe a few papers you would recommend to as a first step?
Very good question. I think if I were thinking about the prediction context and thinking about, do I need to bring causal inference into prediction, I would really recommend Nan van Herleven's paper on predictimans, which was published. Oh, I can't remember now. I have the slides in front of me, so I can go back to the reference. This paper referenced at the top here, published in the European Journal of Epi in 2020. I think that gives a really nice background and introduction to that topic. In terms of going the other way around, about the use of prediction models in causal inference and those doubly robust methods, and that, I mean, I have to confess that there's a big literature on that, and quite a technical literature, which I have found hard to get into. I feel that gradually I'm understanding more about these topics, but there's a lot out there, and a lot of it's very technical. There are some very nice tutorial papers, a couple of nice tutorial papers, which I didn't reference in here, but you'll be able to find on TMLE, for example. I think there's a nice paper in the American Journal of Epi that gives some introduction to how that method works. But I think there's also a lot of scope for tutorial papers on some of these topics.
Awesome. Thank you. I also want to say I really liked your inclusion of visuals throughout the whole talk. I found all of your diagrams and stuff super helpful.
Thank you.
Yeah. It's like, so we have a question from, I hope I said this right, Cameron Tanner. I'm sorry if I did that wrong. They say, you mentioned superlearner. Do you think use of an ensemble is a big advantage in this space, or can we get away with choosing a single method?
Very good question. I think maybe I'll go back to, hi Cameron, by the way. Cameron is one of my former PhD students.
Oh.
And knows a lot more about some of these topics than I do, particularly the use of the superlearner. Where do I go back to? Yeah, maybe I'm sorry, too many slides. So where we were thinking about these different models that we need to specify in causal inference for treatment, censoring of the outcome. Certainly with my training, I suppose my initial tendency is just to reach for a parametric model or a Cox model, for example. But we are possibly making quite a lot of modeling assumptions by doing that. And once one has learned, and there is some substantial setup cost, I think, in learning some of these other techniques, but once one has learned some of those methods, maybe you start to think, well, if I can be more flexible, if those things are available to me and it's available in the software, then it probably is, it's a good idea if I can avoid assumptions, it's feasible, and it can be done in the software, then I should probably be doing that. So. But I'm not sure there's been a huge number of real life comparisons of it'd be interesting to hear if anyone's got examples of where someone has done this in a more standard way, and then someone has used some of these more fancy techniques. It'd be nice to see examples where you do and do not get quite different answers.
Any other questions? We have a couple of minutes. Well, if there's no other questions, I think let's all thank Dr. Keogh one more time. I know I can clap on camera, but everybody else can emoji clap.
Thanks, Sarah.
Yeah, this was really great. I'm really glad you could join us, and it's really great to meet you.
Yes, likewise. Thanks,
Do you
everyone.
mind?
And I look forward to future sessions.
Yeah, absolutely. I would love that. Can I grab a snapshot for this session? Like we'll just the camera. Okay. Ready? 3, 2, 1. Thank you.
Thank you.
Well,
Have a good evening, everyone.
Yeah. Bye, everybody. And stick around for the next session on infection.